So it's all yours, Maria.
Thank you so much, Gary, and thanks to all of you for inviting Sunday Health today to share with you and your group, both live here and through the recording, what we're up to at Sunday Health. So I am joined today by two colleagues. Dr. Doug Elwood is with me, and also one of our team members, Yuritsa, is here as well, and we will be monitoring the chat and encourage you to ask questions as we move along. So I'm going to say just a few words first about Sunday Health and how we will conduct this discussion. And then I'll ask Dr. Elwood to introduce himself and we'll get started. So what is Sunday Health? Sunday Health is, we like to call ourselves a modern cognitive care practice. We're really focused on cognition, so that's issues of memory and thinking. And we come at it from a very proactive perspective. We really are trying to elevate the idea of getting your brain health baseline early, just as you would for your colon health by getting a colonoscopy, or your breast health by getting a mammogram if you're a woman, your prostate health if you're a man. So basically, we have all these checks that we go through as we come into older adulthood, but somehow we forgot to put our brains on the list. So Sunday Health is really trying to come at this from a proactive, preventative point of view, and we'll be talking a lot about that during the course of our discussion today. We do have a full clinical team, which Doug manages and will tell you more about. But just briefly, we have cognitive neurologists, we have nurse practitioners, and care navigators. And this clinical team is here to provide the full scope of clinical care that's needed, from comprehensive assessments of your cognition through diagnosis to ongoing care. We operate today in DC, Maryland, and Virginia. And we do take appointments very quickly. We can typically get people in within 2 weeks or less. We see patients through telehealth, meaning through Zoom like this. And we also have an in-person office in Vienna. So hopefully that's fairly close for many of your members. We take all major insurances and, of course, Medicare as well. So that's briefly what we're up to. We'll be talking a lot more about our services and what we do and why we do it. But the headline is, we are really here to sort of get in front of cognitive health and to help people understand that while there's not a cure for dementia, there are many things that one can do to prevent and delay cognitive decline. So that's what we're going to be talking about. And the way we're going to organize the discussion is I will be essentially kind of interviewing Dr. Elwood, asking a few, kind of level setting questions. We'll spend maybe 15 or so minutes on that. And then we'll try to leave a lot of time for Q&A. And we do encourage you all, again, to just interrupt us and ask questions or put them in the chat. But for right now, I'm just going to turn it over to Doug to introduce himself.
Great. Thanks, Maria. Really nice to be here, everyone. As Maria said, I'm Dr. Doug Elwood. I'm the Chief Medical Officer for Sunday Health. I am clearly a physician by training, but I've actually spent most of my career focused on early identification and creating programs that enhance access. So in that regard, I've been very fortunate to work on some national-based programs for early identification for specific subpopulations. I still am on part-time faculty at NYU. I actually grew up in the DC area, so spent a lot of time as a young kid around Arlington, actually, and growing up. I am not a neurologist, just to put that out there, but my specialty is actually physical medicine and rehabilitation, which is a pretty broad-based specialty that includes a lot of brain dysfunction, including TBI, stroke, and others. And as Maria mentioned, I am surrounded by very highly qualified cognitive neurologists at Sunday Health. I got into this area mostly for personal reasons. I wanted to apply my experiences with early identification and with creating new clinical programs into a space that was affecting me from a extended family perspective. So that's what led me to Sunday Health. And again, it's great to be here with everyone. I'm excited to get this going.
Thank you so much. And I wanted to thank Steve for putting the address of our office, our clinical office, into the chat. And also thank Cheryl for, first of all, having us on the Aging Matters podcast a couple of times. And she put, I think, a link in the chat there. So the topics that we discussed in the most recent episode of the Aging Matters podcast in which we appeared were a little bit different than what we're talking today. So please do tune in and take a listen to those as well. So anyway, I also failed to mention that I live right here in DC. So I too am frequently over in Arlington and all around the sort of DMV area, if you will. But anyway, to get us started in the discussion, Doug, I wanted to maybe just talk a little bit about some definitions and making sure we're all on the same page. I often hear people, by the way, I should also mention, I'm not a clinician. And so Doug and I partner in the leadership of Sunday Health. And so I'm going to ask the non-clinical questions of Doug as the clinician. But I often hear people talk about dementia, and in sort of the same sentence, they'll mention Alzheimer's disease, almost basically interchanging the two terms. But what is the difference between dementia and Alzheimer's disease?
Yeah, it's a great place to start with definitions. So, in its most simplest form, dementia is an umbrella term for a group of symptoms that affect memory, thinking, what's called executive functioning, which is how you do things in your daily life, and other social abilities that interfere with your daily activities. So, while dementia itself is not a specific disease, it's a general term describing a decline in mental ability. On the other hand, Alzheimer's disease is the most common cause of dementia. So Alzheimer's accounts for about 60 to 80% of dementia cases, and it's a specific brain disease that causes the brain to shrink and brain cells to die, leading to a decline in the thinking, behavioral, and social skills that we all rely on. So one way to think about it is a lot of people talk about, you hear doctors and others talk about heart disease, but there are many specific types of heart disease. So there's coronary artery disease, there's congestive heart failure, CHF. There are other subtypes within that. So very similarly, Alzheimer's disease is a subtype, albeit a very common one of dementia. Just because you may have heard the terms, I'll throw some out there. So other causes of dementia include vascular dementia, which is caused by reduced flow to the brain, Lewy body dementia, frontotemporal dementia, and then there's some mixed dementias as well. Each has an underlying different cause to it and may present with slightly different symptoms as well. Alzheimer's specifically is characterized by a buildup of, and you may have heard these terms, but there's amyloid plaques and tau tangles, and those form in the brain, and those interfere with the communication between brain cells. And that's kind of the pathologic and pathognomonic, as we call it, signs of Alzheimer's. And it typically starts with memory problems and then progresses to affect language, reasoning, and then some basic functions. So just to summarize, while all Alzheimer's patients have dementia, not all patients with dementia have Alzheimer's. And the distinction matters, as we'll go into, for treatment and some different types, depending on how you approach it.
Thank you, Doug. The Alzheimer's Association tells us that there are about 7 million people today in the United States living with dementia, or they sometimes say Alzheimer's or related dementias. So you may have heard that phrase, and that's the capturing all forms of dementia. So about 7 million people in the United States today, and as Doug mentioned, about 60 to 80% with Alzheimer's disease. That figure is expected to double, depending on whose numbers you believe, expected to double by either 2050 or to 2060. So it is a growing problem in the United States and really all around the world. And one of our core tenets at Sunday Health is if we want to address this crisis in the United States, we can't wait for people to try to get a diagnosis, because by the time the diagnosis comes, for a host of reasons, it's likely too late to try to really really leverage all the tools in the toolbox. So we'll talk more about that. But just to stay on definitions for a moment, Doug, maybe you could also address the meaning of the phrase mild cognitive impairment. It sounds like a generic phrase, but it's more than that, right?
It is, it is. So mild cognitive impairment, as some physicians call it, MCI, is also somewhat of an umbrella term for memory and other thinking abilities, as you can see on the slide. Those can include a number of different symptoms that can be related, and you can see them all there. But sleep problems, depression, anxiety can all either manifest as an MCI symptoms or contribute to worsening of cognitive impairment. And you can see that there are others listed here, like medical conditions and excessive alcohol, that go into worsening it. It's basically, if you think of it as a continuum, from normal aging into a start to change into a pathologic change, which leads to MCI, which can then lead to mild dementia, which can then lead to moderate and severe. And those are all based on a number of different factors. Um, Thanks. And this is starts to go into that a bit more, and we can talk about that. But from a basic definition perspective, MCI is on that continuum and is a first step. And as Maria said, that's where we like to focus with Sunday Health most aggressively, because that's where you can really start to affect this curve as you're seeing, and the downward slope. So we like to keep it as high as possible. And that's where we really aggressively start to talk about the modifiable risk factors, which we can go into in a bit here.
And so you mentioned normal aging, Doug.
Yeah.
So what, maybe you could talk a little bit about how can one be thinking about the difference between normal aging and what happens with your cognition under normal aging compared to cognitive decline?
Of course. So normal aging involves some expected changes, right? As we get older, there are expected changes in cognitive function, versus the pathological cognitive decline that is more severe and interferes with daily functioning. So let's start with normal aging. So normal aging, the brain naturally changes with age, as one would expect, and it leads to some predictable cognitive shifts. So processing speed typically slows down. So for example, you might need a bit more time to recall a name or solve a problem. Word finding can become challenging. It's sort of that tip of the tongue phenomenon that those moments can increase with normal aging. Multitasking can become harder. You might find it takes more time and effort to learn new information or switch between tasks. These are all examples of normal aging, but these are generally mild and don't significantly impact your ability to live independently or perform complex activities. And most importantly, kind of that accumulated knowledge and skills often remains stable or even improves in some cases with age. This is all as opposed to pathologic cognitive decline, which goes beyond the normal aging and includes conditions like MCI that we've talked about, and of course, dementia. The changes are more pronounced and progressive, and memory problems can become severe enough to start to affect your daily life. So, forgetting important appointments, getting lost in familiar places, having trouble managing finances, language difficulties that go beyond the occasional kind of word finding, what's that word again, to real problems understanding conversations or expressing thoughts as well. So, kind of the key distinctions lies in the functional impact, is one way to think about it. So, normal aging might mean, again, kind of occasionally forgetting your keys, while cognitive decline means that you kind of forget what your keys are even for. So that's where it can really start to manifest as the difference. And normal aging can be slower, whereas pathologic decline involves impaired judgment and problem solving that affects both safety and independence. So, and the final one is just progression. So with normal age-related changes, they tend to be gradual and stable, whereas pathologic decline cannot worsen over time and can be much more rapid in its progression.
Thank you. I'm going to switch to asking about the modifiable risk factors, which we've mentioned a few times here. But before I do, I just want to invite anyone who might want to jump in with a quick question. I see, Wendy, that you put a good question in the chat. I'll answer that now. And anyone else who wants to ask a question, feel free to jump in behind me. Wendy, your question was, do you need a referral for your assessments to be covered by Medicare and other health insurance? The answer is no, you do not need a referral. You don't need a referral to make an appointment with Sunday Health, nor do you need a referral for our services to be covered. Some of our patients do not have PCPs. Many do. We're happy to take a referral from a PCP, and we have a number of local PCPs referring to us now. If you don't have a referral, we will likely ask you if you want, and you do have a PCP, we will likely ask you if you want us to share the results of our assessments and our findings with your PCP. There's another question that just came in that says, it's interesting how some people are super agers. Cognitively, they are sharp as ever, genetics question mark. And yes, thanks, Steve, PCP equals primary care physician. So on this topic of genetics and superagers, that actually does relate to modifiable risk factors. So Doug, my first question for you is, what's the difference between modifiable risk factors and non-modifiable risk factors?
Yeah, exactly. So there was a report that came out, a couple of reports, but one most recently was last year that identifies 14 modifiable risk factors. And those modifiable risk factors, as the name implies, are ones that can be directly changed versus ones that, like genetics, as pointed out, cannot be changed. So, and we can talk about genetics briefly after. But from a modifiable risk factor, they identified 14 different modifiable risk factors. And the main point that's very exciting about those modifiable risk factors is that the commission that was called the Lancet Commission that published it found that around 45% of dementia cases are potentially preventable by addressing the 14 modifiable risk factors. And that's actually an increase of what they estimated previously at about 40%. So you can see all of them listed here. They range from quality of education and air pollution, which are somewhat out of our control, to many that are directly in our control. So hearing impairment, depression, social isolation, some comorbidity thinking around diabetes and obesity. There's physical inactivity, and you can see the whole list here. But the idea is extremely important. And again, one that Maria's already mentioned and I mentioned is that jumping in early, just like heart disease and just like diabetes, makes a difference. So you go to your doctor all the time and you can hear them say for your heart and for your other organs like diabetes and kidneys and everything, that diet and exercise is really important. Not a big leap to think that that's also very applicable to your brain, but it even goes more in depth. And we talk to a lot of physicians and we do a lot of education around this topic specifically because even they, a lot of them just aren't able to keep up with the literature as much as we are very focused on it. So we help educate them and let them know that in fact there are these modifiable risk factors. And just like most disease states in medicine, there are ways to decrease the risk of worsening or getting those by taking certain steps. So these are your modifiable risk factors. And just to quickly return back to the genetics, there is a gene called ApoE4. That's ApoE4. And there are different variations of ApoE. Since my training, it's developed quite a bit. So those are genetic factors which do contribute to how your age correlates with your brain activity, et cetera. And there are these modifiable risk factors. There is another element to this called cognitive reserve, which is what we've found and is well published and studied that a lot of individuals with higher education, with a lot of these modifiable risk factors in the really good state, are able to maintain a level of cognitive function, even though their brain cells are starting to change, which again is a really big reason for early identification and getting baseline assessments because changes can be happening without symptomology. So, just like with your heart, changes can be happening, your vessels can be getting a little clogged, and you might not necessarily know that. So very similarly with your brain, changes might be happening with those amyloid plaques, as we talked about. And it's important to understand where you might be from a baseline perspective so that we can then monitor it over time.
Thank you, Doug. I wanted to point out that Yuritsa just put in to the chat the Lancet Commission on Dementia report that Doug was just referencing, so that a link to that is in the chat. I also want to point out, if you go and read that report, although on that slide that Yuritsa presented with the 14 risk factors, modifiable risk factors, you won't see sleep or nutrition specifically. But if you read the report, the sleep and nutrition are called out. And so I mentioned that because in our practice at Sunday Health, if someone comes through our process, even as soon as the first appointment, we would be asking about some of these things, sleep habits, nutrition, and maybe Doug, you could talk a little bit more about that, because I think it's important to point out some of the items that didn't make the 14 modifiable risk factors, but are known to be important to cognition.
Yeah, absolutely. As Maria is saying, we definitely spend a lot of time trying to understand the modifiable risk factors and dive into those. And something like sleep is a very, very broad term in reality to how somebody's sleeping, what the dysfunction could be with the sleeping. And if it's clinical, like something like sleep apnea, if you've heard of that, or something that's non-clinical, which is just maybe more having too much caffeine before you go to sleep or doing too much activity right before bedtime. And there are certain patients that have trouble falling asleep. There are other patients that wake up in the middle of the night. So there's a lot that goes under just sleep. So it's important to distill that, to understand it, and then to dive into a plan to go into that. And there are a number of other factors and comorbidities that are close to being on the list, as Maria mentioned, and but a lot of them kind of ladder up to that same approach of what can we do for our brains that's very similar to what we would do with our other organs and just in general health. So from an overall perspective, that's how it all coalesces and how we are approaching it at Sunday Health as well.
Thank you. We have a couple questions coming up in the chat.
Yeah, I see that.
Wendy, we will address your questions about what happens in our process in a moment. We will talk about what we do and how we do it. But I want to move to Jim's question because it is still within the modifiable risk factors, and that is, can you comment on alcohol use?
Yeah, so alcohol use is somewhat like sleep, where it's not just a black or white, a 0 to 1, do you drink alcohol or not? It's really around the consumption of alcohol on a continuous basis and how much you're doing. So as a physician, the way we normally ask about that is how many drinks are you having either per night or per week? And from that, we're able to start to dive deeper into, well, what are you actually drinking? Is it a mixed drink? Is it beer? Is it some sort of other alcohol? Is it wine? And start to dissect more specifically what that means. The same thing we used to ask a lot more, not so much these days, but around tobacco is how many cigarettes. And from a physician point of view, what we then do is calculate a kind of annual score. And that can be then used to determine kind of where you lie. Of course, everyone is a bit different in how they uh, process the alcohol they're consuming. But with that said, there's definitely limits on how we're thinking about that and how much you should be doing, especially with regard to MCI. So a bit of a vague answer there, I understand, but it's really person dependent and dependent on some of the factors that go into the alcohol consumption.
So then one other question from the chat before we move to the next portion of our discussion, which will focus on some of the new tools in the toolbox. The question is, I read about, this is from Pat, I read about a study somewhere where elderly patients who were very bright, but on autopsy, it was found that they had amyloid plaques in their brains, yet exhibited little or no signs of decline. Are there any studies on the differences in how this is presented? I think you addressed a little bit, Doug.
Yeah, a little
Yeah.
bit, but it's a really key topic because actually, even now, the ultimate and only way to accurately diagnose Alzheimer's is through pathologic exam, which means actually taking some of the brain cells. So that's not the most efficient, and we'll come back to that because fortunately there are some advancements in that are just recently even coming out and being approved by the FDA. But this goes into a few different topics. One is the modifiable risk factors, another is the cognitive reserve. And it's again very well known that high cognitive reserve can actually lead to normal daily living activities, but from a pathologic perspective, can be show signs of disease progression. So that it can be a number of factors associated with that, but the studies that you're asking about are key. There are many, and they're key to us understanding where the pathology is and some of these other features like cognitive reserve.
So, Doug, since you just mentioned it, it's a natural transition into, you mentioned that FDA approval, some recent approval. Maybe you could touch on that and specifically the blood test and how the blood tests are and are not used, as well as the newish FDA approved drugs.
Yeah, absolutely. So just taking a step back for a minute and thinking about diagnosis. So there are a number of ways that we can diagnose dementia or Alzheimer's and other dementia forms. One of them is through assessments. So there's something that we do at Sunday Health called neuropsychological testing, and that's a battery of tests that looks at all of the different layers of how your brain functions, from, of course, memory, which is what everybody thinks about most predominantly, but also executive functioning and spatial awareness and things like that. So you can see from the slide, there's the neuro exam and the cognitive testing. But very excitingly, there's this whole new domain of blood-based biomarkers. And blood-based biomarkers are basically our ability to take blood sample, your normal blood sample, and look to see if there's amyloid deposition in your blood. So whereas we used to have to get what was called historically a spinal tap or cerebral spinal fluid, where you go into your spine and you take a lumbar puncture and you take that fluid and you examine it, now much easier and much more comfortably we can take a blood test. And that's on top of imaging. So imaging, as you can see here, there's MRIs, which have gotten increasingly sophisticated and are very, very specific around looking for this. There's some forms of CT scan, but those aren't quite as good from a sensitivity and specificity perspective. And then there's something called a PET scan, which is also quite sensitive and specific around picking this up. But with all of these, none of them by itself is a diagnostic criteria. So right now we're still in early stages of putting these all together, and things like AI are helping just from a data aggregation perspective and putting all the data together and understanding how it works. And we're working with some of that as well. But from the blood-based perspective specifically, the FDA just approved a combination of blood-based biomarkers that you can see here, and it fundamentally looks to see if there's amyloid deposition in the blood, and can then help us as clinicians determine where you are in your kind of personal journey of, is this becoming a problem? Is it already here? How is it going to manifest? There are still some open questions, of course. This is very new, but it really helps with our armamentarium of tools to understand from a diagnostic perspective where an individual is and how then to combat it. Because some of these now are also linked directly to the medications that are coming out. So it's a really exciting space and one that's developing really rapidly, actually, after having not much activity for a long time. So we're excited from Sunday Health, obviously, because it really affords clinicians with a better opportunity to understand more, just like we do with other blood tests.
Um, Doug, there's a question in the chat. Is the blood test covered by insurance?
So we are, from our understanding and our own use of it, about 70% are covered with a copay, or sorry, 70% are covered fully with the right diagnostic criteria. So it's important, for example, to go to a doctor who understands what they're doing. We are very good at tying the blood test to the assessments. Some who are not quite as familiar with it might have a little trouble with that. And then, but even with that, about 90% are covered with a copay. So it just depends on insurance type and everything. But because they're so new and FDA and Medicare and private insurers are still trying to fully understand the import of these blood-based biomarkers, there is some importance to tying the blood test to some of the assessments as well, so that you're using them as a diagnostic within the diagnostic framework and not as a screening tool, which up to this point is not approved.
And Carolyn is asking, should I request the blood test now as a baseline?
I'd say it depends on the individual. So you should definitely be talking to your physicians about it. But if your assessments are clear and there's no other signs or symptoms, it may be able to wait on it. We are of the opinion that they're very important to add to the baseline, and there are some more than others. There's 5 or 6 tests now. There's one, probably the one that's emerging as the most predominant test is called p-tau 217. There's also a ratio that's called the plasma 42/40 ratio. And there's a few others which names get increasingly long and complicated, like neurofibrillary tangles and things like that. So but the basic premise is that these lab tests do help form a baseline picture and hopefully can help track over time. The literature on that is still being developed, but again, we are firm believers that this paradigm is shifting and it's shifting fairly quickly, and that p-tau 217 could be the marker that in a few years does become more ubiquitous as a baseline assessment tool.
Thank you, Doug. Rosamunda, I see your question is what is the name of the blood test? Yaritza put the name of the FDA cleared blood test, which has a brand name, in the chat there. But as Doug just mentioned, there are actually at least a half a dozen blood tests. Only one so far cleared this Lumipulse test, which is in fact a ratio, as Doug just called out. But you know, the main idea here is the measure of the p-tau 217 and or the ratio, as Doug just mentioned. So we're happy to talk to you more about that offline, but just to be clear, there are multiple tests and only one so far cleared by the FDA. But that clearance, as you may have noted in the press release, that just happened like 5 weeks ago. So when we say recent, we mean recent.
Yeah.
I know, Cheryl, we'll address your question when we talk about our process in a moment. There's just one other question I want to ask of Doug before we switch over to what exactly happens at Sunday Health. And that question, Doug, is could you just chat for a minute or two about the new monoclonal antibody drugs, which have also recently been approved by the FDA? What that recent is within the last couple of years, but what are they? Who are they for? What are the pros and cons?
Yeah, absolutely. So there are 2 new types of medications, and as Maria mentioned, they're both called monoclonal antibodies, and they are disease modifying, which is a specific class of medications. And really, we talked about amyloid. The idea of the medications is to bind to and remove amyloid. So you get through an IV, either once every 2 weeks or once every month, the infusion. And you can see here, there's Leqembi and Kisunla. Eli Lilly and Eisai Biogen make these. And it really is around removing those harmful proteins that are developing and getting it so that there's less of them in your brain, which can then, which obviously, as we talked about, it hampers communication of your brain cells. So you can see here, the efficacy is still, it's really good or still developing. It depends on how you approach it and who you talk to. But the idea that there are 2 new medications and that they're tied more increasingly to either the blood tests or other imaging modalities points to a brighter future for this space. And we can tell you that we work very closely with clinical trial companies. We work very closely with infusion companies. And we know that there are others on the way that are very exciting from a preventive perspective and hopefully from a treatment paradigm as well. where, for example, instead of IV, you can get it in easier ways, even in the home. So these things are all on the horizon. And again, very exciting to see it developing. There are some side effects and complications with these medications, as you might expect. One of them is called ARIA, which is actually just a more of a radiologic term, which is amyloid-related imaging abnormalities. But because it's binding to and removing proteins, there are some potential side effects. So really important, obviously, to discuss the pros and cons with a physician and to get the ability to speak to that physician early because the medications are for early dementia or mild, not for the moderate and severe. So once you get beyond a certain point, the efficacy does decrease. So again, everything we're talking about is early identification, yet another reason to jump on this early, get a baseline, understand where you are, because you may be eligible for the medications earlier in the progression, if you can catch it.
Absolutely. And it is exciting, Pat. We agree. That's actually, one of the core ideas behind creating Sunday Health is that the approach to diagnosing, treating, everything about dementia care is really kind of at a moment in time where we see a paradigm shift happening. And just as Doug has mentioned several times, a parallel with heart health, if we think back 3 or 4 decades as to how people approached heart health, it's very different today. I mean, people understand what statins are, and people understand, that they might need to be monitoring certain body blood certain biomarkers, I should say. And we don't really have that mindset for dementia today or cognitive decline. And we think that is definitely changing with the advent of new blood-based biomarkers, new drugs, new research that really speaks to the efficacy of the modifiable risk factors. And that's a lot of the reason why we exist. So we think it's exciting too. So what do we actually do at Sunday Health? There's a few questions about this in the chat. I'm going to just say a few things and then Doug invite you to really go into more detail. First of all, I do want to repeat, we can see patients anywhere in Virginia, Maryland, or DC. They can come into the Vienna office on Old Courthouse Road, or they can see us through telehealth. We have very good experience with telehealth, and most of our patients do choose to be seen through telehealth. Our process, the first thing that happens if you make an appointment, whether that's a referral or not a referral, we do not require a referral, is you would have a brief telephone call with our care navigator. And that purpose of that telephone call is to sort of align, make sure we understand where the patient is in their journey, their goals, their insurance coverage, their comfort with digital interaction or not, whether they have a care partner, does that care partner want to be involved, and if so, how? So we kind of cover a number of the basics. And at that time, then, assuming it's all a go, we would go ahead and set up the first appointment. So the care navigator would help with all of that. After the appointment is established, an email will be sent to confirm that appointment. In that email, there is a very simple link to what's called a digital cognitive assessment, and Doug can speak about that. But it's basically a short exercise that we ask patients to complete online on an iPad or a computer prior to the appointment, so that at the first appointment, that nurse practitioner can start with a little bit of information that will help her in what she's trying to do, which is in that first appointment, which lasts for 1 hour, the nurse practitioner will be asking sort of full medical history, symptoms. She will also be administering a couple of additional screeners such that at the end of that first hour appointment, it's almost always, if not always, possible for her to say, yes, this person is, cognitively normal for their age or not. And from there, the process would continue. And so I'll stop there, and Doug, let you pick up, whatever you want to talk about with respect to what our process is, what we're trying to do, how diagnosis is done. And Steve, I do see your question, and I think Doug addressed it, but we'll come back to it right after this.
Yeah, so the way we're approaching it is we call it the map. So literally and figuratively, we are creating a map that's very personalized to our patients. And that MAP actually is an acronym. So the M is the modifiable risk factors. So as Maria said, we spend a lot of time looking at the modifiable risk factors, talking to you about them, and coming up with a plan for them. The A is for assessments. So as Maria mentioned, we start with some kind of baseline fundamental assessments, and as needed, progress those to very sophisticated, longer, and more in-depth assessments like the one I mentioned around neuropsychological testing. The P is actually twofold. One is your personal situation. So, have you thought about home safety and things like that, depending on where you are in your journey? And then the other is physical, and that physical represents the blood-based biomarkers, imaging, and other modalities that we have at our disposal. So from that map, we're able to then put together what, with our nurse practitioners and our cognitive neurologists, and of course with you and your loved ones, if they are want to be included, a plan for how you're going to get through the map to better care. So that's the way we approach it, and we do a very similar approach for every patient. But of course, everyone's map is quite different in how we're gathering the information and then taking steps that are personalized to you.
And I just want to, Doug, maybe ask you to go ahead and comment on, as I was describing the process, the first appointment being with a nurse practitioner for 1 hour. If somebody is basically not testing within the normal range, what would happen next at Sunday Health?
Yeah, so right now, what we would do is get you to our cognitive neurologist, and that cognitive neurologist would review all of the information and most likely do a neuropsych test, as I've mentioned. That is a much longer, more comprehensive test. Some of our NPs are starting to do that as well, but regardless of who does it, it would be a more comprehensive battery of assessments that would then work with the other information that we're getting. So if we haven't ordered blood yet or imaging yet, we may also do that. And then we collect all of that. And the goal would be not to get all this information, tell you what's going on, and then never talk to you again. It's quite the opposite. What we do is we strongly encourage our patients to come back, spend more time with us, go through the other components of that map that I was referring to, and really spend time on understanding, is it the modifiable risk factors? Which ones? How are we doing with the assessments? Where are we with the baseline? How is it evolving over time? What are those physical and personal components that we can be talking about, focused on, and really then go from there as a process that's personalized for our patients.
Sorry, follow-up question in the chat. Do you work with PCPs for referrals or refer for testing yourself?
We do both. Mostly we do the testing ourselves, but we work very closely with a number of PCPs in the DMV area. And we really want to be sensitive to their process and their what they'd like to do. So if they want to be more in control and order the tests, that's completely fine with us. We've done a lot of education on what they should order and what they should be looking for. We've found that just given your normal primary care physician, their workload and the number of different kinds of patients they're seeing in their daily activity, that it's difficult for them, as I mentioned, to kind of keep up with all the latest and greatest in every single disease category. So another big reason why we exist, just like the specialists in other areas exist, so we can help them a lot. And so what we find is that a lot of primary care ultimately prefer that we do it because we know then how to interpret it, and we're very plugged in, as I mentioned, to clinical trials, into infusion centers, and to a lot of the emerging literature and research. So we're just better equipped to have longer conversations as well with patients than most primary care docs. But we will work with them as closely as possible to give them recommendations, feedback, and let them run the show if they prefer.
Thanks, Doug. Steve wanted us to go into a little bit more detail on the genetic factors, specifically how indicative is family history of dementia or Alzheimer's?
Yeah, I mean it's pretty high on the list, just like with heart disease and other disease categories. Genetics plays a fairly big factor. I'd have to go back to the literature to get you a specific number of how genetics relates to the modifiable risk factors, for example. But there are certain alleles or types of the gene ApoE, as I mentioned, like ApoE4, that definitively puts a patient at higher risk, especially if that patient has two alleles of the ApoE4 that is correlated with higher risk for specifically for Alzheimer's. And to this point, precludes them from most infusion centers for the new modifiable treatments. Not all. Some physicians will still do it, but just because it increases the risk for some of the side effects. So I can come back with a better number, but it can be hard to quantify as well. But genetics definitely plays a big factor.
Yeah, there was another question about showing the slide again. Actually, the slide had the question is at the end, to please show the non-modifiable changes. Yuritsa, you could pull up the 14 modifiable risk factors. I think among the non-modifiable changes are things like your genes, most
Number one.
prominently. But it can also be, where you're born. You can consider that non-modifiable, even though one can move, but typically not as a child. So, as you're born in a place that might have poor quality education or, poor air quality, those things, they're listed as modifiable, but there's always a little bit of discussion around what's truly modifiable that's happening early in your life. Doug, I don't know if you want to add anything to that on the non-modifiable side.
No, I think you got them, Maria. The biggest one, yeah, is genetics, and then some others fall into that other category, like you're mentioning.
Yeah. Um, I hope that answers the question. I think, we cannot stop saying this, but it really is critical to remember that just like with any other disease or chronic illness, early identification and the development of, lifestyle factors that can help prevent and delay cognitive decline is just incredibly important. And there is a lot of literature that supports that. So I think a great final question here is from Cheryl, which is any predictions as to new findings and therapies for addressing MCI and mild dementia?
Yeah, it's a great question to end with because as you've heard, I'm pretty excited about it, and where we at Sunday Health are excited about this evolution of both of treatment and diagnostic modalities. So I think what we'll see in the immediate short term and what we're already working on and others are is combining these different data points. And I mentioned AI. One of the great attributes of AI is just the ability to synthesize huge amounts of data and get them into a reasonable format and output. Um, and we're already seeing that in this space where we're able to collate a lot of information very quickly, very easily, and put it together to understand. So that's one aspect of this journey that we're really excited about is just we see it and we're doing it ourselves of collating information and combining it to tell a better story of where an individual is in his or her own journey. I think as I mentioned, the treatment paradigm is continuing to shift so that we're getting increasingly upstream in the sense of prevention. So hopefully in the near future, we'll be able to see some medications that actually help prevent amyloid creation in the brain, which could be really exciting. And then just a transformation of how these medications are given, from the IV infusion to other ways to give it, for example, and with the diagnostics. So MRI can become even sharper. The blood-based biomarkers can get more evidence and really become a mainstay so that just as you get your other labs when you go to the doctor, you can get this one, and it can be a really huge shift in both how we're diagnosing and then thinking about the prognosis and continuity of a patient's care. Because as we're able to coincide those, it could be really, really nice to show how modifiable risk factor correlates with that reducing number. And there are already some studies that show that. So I think that's what's coming, and it's exciting.
Well, thank you so much, Doug. We want to close out here by, first of all, thanking all of you and your group. And we're big supporters of the Village Movement and have talked to several other village groups here in the DMV. So thank you for all you do. And thank you for including us today. Steve, thank you for posting again in the chat. That is our location in Vienna, our phone number, our email. If feel free to reach out. Here's all the information again. This is all available also very clearly, we hope, on our website. We are taking new patients. You don't need a referral. So if anything we've said here today resonates with you or any of your friends or members, please reach out. We'd love to hear from you. And we do have one very specific ask for any of you who may be interested. We're currently working at Sunday Health on some new services that will be clinically grounded, but helping to address the modifiable risk factors. So you could think of these as like a products in development that would be like a trainer for your brain or a trainer for your cognition. And we're seeking some input on the development of those products. So if anybody is interested in sharing your thoughts or reactions to things that we could show you, we would love your input, almost like a beta tester, if you will. And you could either put your email in the chat now if you're interested in that, or just email us if you would be willing to share some feedback with us as kind of a reaction to products in development.
Right.
So
Maria, you made me see me making noise. I love being a secret shopper. And I'm prepared to make an appointment for a baseline assessment. I think it's such, as I mentioned in the chat, I'm got a friend going through this right now, and I've learned so much from just sitting in with her at appointments on much of the things you've talked about today, that I'm now thinking, how does it apply to me? So this is really very, very informative for me. I really appreciate it. Easy to understand from what you've talked about. And especially thinking about what are the treatments and preventative actions that we can take beyond doing the New York Times, word games.
Yeah, well, thank you, Wendy. We would love to take you up on both, seeing you for an assessment, but also, as a product discovery type of interactivity. Rosamundo, Yuritsa put the email in the chat there. If anybody wants to email us, either to make an appointment or to volunteer to react to our product in development, that would be hello@sundayhealth.com. And I'll just close out here by saying, one of the modifiable risk factors, if you didn't notice it on the chart, had to do with socialization. And so you all should be patting yourselves on the back, because at the top of this session, I heard Carolyn list a whole load of activities that you all are participating in, which are good for your cognition, participating with others, supporting others, getting out and doing things in the community. That's great. That's all about socialization. So look, you can check one of the 14 modifiable risk factors on the list. So congratulations to all of you, and thank you again.
Thank you.
Have a great day, everyone.
Thanks so much.